Good afternoon. My name is Rich McKee, and we welcome you to the Fast Break webinars, kind of bite-sized views of value-based healthcare. We are grateful for our co-hosts, the David Eccles School of Business at the University of Utah and the Green Templeton College at the University of Oxford. We appreciate as well our contributing sponsors, Intermountain Healthcare, Select Health, J.P. Morgan, and Levitt Partners. We recognize that we are in the process of framing better the symposium, which is scheduled for May 11th through 13th in 2021. And more details will come out as we begin to focus on an online as opposed to an in-person symposium, and that should be available by the time we meet again. We are grateful to recognize with us here today Dr. Nick Hicks, a physician from Great Britain who is the associate fellow of the Green Templeton College at the University of Oxford and the lead of the management of medicine program there. He's also the CEO of COBIC, which is a consultancy that deals with value-based healthcare and with outcomes-oriented healthcare. And we're really delighted to have Nick, who has become a wonderful colleague and friend along the way as we've matured this relationship between the two universities. So Nick, we welcome you.
It's a real pleasure to be here.
So let's start with a description here. I think in the United States we have some misconceptions about the National Health Service in Great Britain. Would you give us a background and description of that so that we are on equal footing?
With pleasure. So the National Health Service in England, or in the United Kingdom, was created in 1948, which, as you all know, was immediately the period after the Second World War. And I think that's really important because the Second World War, Europe was ravaged for the second time within 30 years. And there was a real feeling in the population, actually we had to create a country which was fit for everybody, for returning heroes. The whole country had been involved, poor had worked alongside the wealthy. And there was a really seminal report that led to the foundation of the health service called the Beveridge Report, in which William Beveridge, a senior civil servant, described 5 giants of want, that's poverty, ignorance around education, squalor, that was housing, disease, which is the health service, and idleness, which is unemployment. And the country was determined that the whole country should tackle those wants. And the principle of a national health service, free at the point of delivery, funded out of general taxation, arose from that desire. And perhaps it's not surprising, thinking of that history, that the most similar thing in the US, of course, is the Veterans Administration. But the Second World War meant the whole country had been involved, so we got a universal system. So those principles of free at the point of delivery were reflected in the tax-funded system in which everybody contributed, and resources would be allocated according to need, not ability to pay. And it rapidly became something that was close to the heart of citizens and the common set of values that the country had emerging from the Second World War. And now, it started with a relatively small budget, which is £400 million or so at the time, which is equivalent to about £16 billion, so that's something under $20 billion. And it's now risen to over $150 billion, which is 10% of our GDP. About £3,000 or $4,000 per year per person. And it remains hugely popular with the British public. Every poll, it always becomes a personification of what it means to be English. The health service demonstrates the country's values. And the money that's risen through taxes is then distributed to local parts of the population according to capitation, and used to buy care largely from publicly owned hospitals or publicly contracted primary care, and provides care which then is free at the point of delivery, with people's main first point of contact being through their primary care doctor, with almost every citizen registered with a primary care doctor.
So you've spent a fair amount of time in studying these systems of healthcare, both payment and delivery of services. So describe a little bit the similarities and differences between the National Health Service in Great Britain and the US system, and kind of identify, if you could, the key challenges that exist in the National Health Service.
Well, I think some of the differences, of course, of the way in which money is raised, as I've described with the health service, largely tax-funded single-payer system, as opposed to the much more plural and private sector organised US system. But I think the similarities actually come in the delivery of care and the challenges that both systems, in fact, probably systems around the world face. Access is, of course, a problem, but it manifests itself slightly differently in our two different countries. In the UK, the financial barriers to access for the individual have been removed by the single payer system. But given that supply perhaps is exceeded by demand, access the challenges of access are translated into waiting times and perhaps also a reduction in choice. By contrast, I think in the US, choice and speed are very much baked into the system, but access is perhaps limited more by the ability to pay and the degree of coverage that people have. Also, I think both systems have major challenges with the reliability and quality of care and with waste. And indeed, the first speaker in this series, Brent James, highlighted some of those. And the link between waste and quality is very significant in both countries. Effectiveness and the ability to improve health is hugely important, as are many questions of efficiency. So I think those are some of the core similar challenges that we both face.
So you've referenced the concept of sustainability, and you and I have had a number of conversations about the sustainability issues related to both systems that you and I operate in. Talk a bit about sustainability and the issues that relate to that, particularly in the NHS system.
So sustainability in the sense of this conversation is less about sustainable in climate change terms, but the sustainability of the system to be able to provide and deliver healthcare. And I think what's common, the system will be sustainable if it delivers value to individuals and society that people are prepared to continue paying for, whether through their taxes, as in the UK, or through their insurance premiums or fee-for-service in the US. And if a system fails to deliver on the value that people expect, that's when systems, I think, are in danger of becoming unsustainable.
And now we've talked about value and value in the context of payment systems and value in delivery systems. And how in the NHS do you describe value? And I'd really be interested to know how you, in a single payer system, became intrigued with and interested in value and waste and the kind of concepts that you've already discussed.
So there were two questions in there. So one was around the way the system defines value, and then the second was how do I become interested. I'll start with the second. I mean, the second, it actually began as a very young doctor when I was working for the professor of cardiology here in Oxford. And we were involved in the randomized control trials for simple treatments of heart attacks. They were called the ISIS studies, the International Studies of Infarct Survival. And one of the key results of one of those studies, which was a study of nothing versus aspirin versus a clot-busting drug, streptokinase versus both, was that the survival curves for aspirin and streptokinase were superimposed upon each other. In other words, aspirin was as powerful at reducing people's risk of death in the middle of a heart attack as the clot-busting drug. And then I was surprised at our reaction as doctors, as hospitals, where we got all excited about the sexy streptokinase. We talked about daughter needle times, reperfusion arrhythmias, and probably forgot to give people aspirin. When you looked at the audits, 50% of people only got aspirin. And the same actually was true at Mass General and around the world. It seemed to be a common problem of our hospitals. So I became interested in how evidence translated into practice and how, because the evidence seemed to me a really good guide to how you deliver high value care. And it led me through to this career about why is there this big voltage drop in what systems could be delivering and what do they actually deliver. And then you come into all the funding mechanisms, the efficiencies and the waste. So that was my personal journey. And what I discovered within the systems was actually value was, we started off as a very technical approach, cost effectiveness, cost per cost utility studies, extended then and would support, I think, very much Michael Porter's definitions of value, the outcomes that matter to people, how much of those you achieve per unit cost. And then also realizing that as well as the measured and explicit values, there's a lot of things that are implicit. So we talked a bit about the funding mechanisms. So the values of society that matter to people individually and collectively also have to be delivered in the through healthcare systems. So I think in much of Europe, people believe healthcare to be a right, not a commodity. They place collective security probably higher up on the value chain than choice. Whereas I think in the States it's different. And so the different funding mechanisms are delivering value according to society's values, as well as the technical efficiencies around that both systems have to grapple with.
So it's been fascinating to me to have these conversations with you. Now in the sustainability area, how do you see the correction of that in the NHS? In other words, is it a mere tweak, or is it an overhaul, or an evolutionary process? How do you see this working, and how do you see the mechanics of it being implemented?
As the tensions in the system grow, the gap in particular between supply and demand, as that widens, I think it's more than just simple cracks. It's and that demand is growing because as our population gets older and there is more illness, as medical technology advances, there's more that can be done. So the demands on healthcare systems rise and have been rising faster than the ability to pay. And that creates very significant tensions. And unless we address those tensions effectively, then I think systems are likely to become unsustainable. And as two of the major routes which the NHS adopted have also been reflected in the talks of the prior conversations in this series. First, Brent James talked about waste, and that's been a major theme of efforts within the NHS. So waste tightly linked to quality, and indeed the US Institute of Medicine a number of years ago defined poor quality as misuse, overuse and underuse of care, all of which are forms of waste. And so there have been many initiatives around identifying and improving quality, which are linked to this agenda of reducing waste and reducing that gap between supply and demand. And then Mike Leavitt talked about public health as a mechanism for reducing illness and therefore reducing demands on care. And both those are major themes, not just in the US, but within the UK. And we've had many major initiatives, of which some are internationally recognised, like the Cochrane collaboration, identifying what works through systematic reviews of randomised controlled trials, and the National Institute for Clinical Effectiveness, NICE, which has produced major guidelines which are very strongly evidence-based. And there's been a very constructive academic dialogue between the US and the UK over many years around both those topics. So
you referenced Brent James, and he has this equation that waste and quality go together. Elimination of waste leads to quality. Talk a little bit about that in the NHS system and how you've thought through that.
So waste and quality, as I mentioned, the Institute of Medicine's classification makes that link very clear. When you consider poor quality as overuse, i.e. doing things that don't work, that's waste. Misuse, which is doing things wrong, creating harm, that's waste. Or underuse, allowing people to get sicker, therefore requiring more complex care later on. And a very major strand of that through the UK has been, if you like, health services research, health services epidemiology, and the identification of effective treatments and cost-effective treatments. that are built into increasingly first professional and then nationally mandated evidence-based guidelines. So that strong link to evidence has been a really major push on the delivery of value. And more recently, that's also been combined with a more explicit understanding of the importance of understanding the values and the preferences of each individual patient, because sometimes they don't, their values will, the outcomes that matter most to them will determine which treatment will give them most value. So I think the combination of understanding effectiveness, identifying variation, some of which is warranted and some of which is unwarranted, have been major drives. There have been major programs all the way through the system, built and reflected and probably held first and foremost through the system of guidelines and guidelines mandated to the service, published through the National Institute of Clinical Excellence.
Now, you've kind of had a background in primary health and in public health. So in one of our prior webinars, I know we've talked about this, Governor Mike Leavitt began to talk about this as Public Health Day. And I know you've spent a fair amount of time on that. So is that taking root in the same way in the United Kingdom as it is in the United States?
It is beginning to, I think. I think there are seeds, particularly in a phrase that is increasingly owned by the National Health Service, in the phrase population health management. I think that, I think it means something slightly different to population health management in the US, because the foundation of care within the NHS is primary care. And we have the great advantage that almost every citizen is registered with a primary care doctor, and primary care has led the way in the use of electronic patient records. So many primary care doctors have 10, 15, 20 years worth of full electronic records held within their systems about the people that present to them and also the people that don't present to them. And for many years, that system has allowed the practice of really good preventive medicine, immunization programs and so forth, screening programs, grounded in that population register. But now, I think increasingly, population health management is coming to mean that set of systems and processes that are designed to improve health, reduce inequalities, and relieve suffering in a defined population by, and this is important, three things: by better responding to the demand that gets presented, and that includes the better coordination of care across settings. The second by is by being proactive, by understanding what care works and being proactive in getting that to the people who haven't necessarily sought it, making sure the offer is there for them. And then thirdly, this is perhaps the more traditional piece of public health, working to create the conditions in which people can both live healthily and take healthy decisions about their life. And increasingly, that is allowing the health service to engage more broadly with local government and other employers, people whose decisions shape the environment and the choices that people make. So it's beginning to combine both an individual approach, the individual choices, with the influences around people that shape and can mold some of those choices.
There are lots of things that we could continue to discuss about this, but our 20-minute framework is not probably going to allow us to get further in depth. But there is one issue that I think is interesting for consumers here, and that is, what lessons ought we to be learning about that are coming out of the European systems that would be applicable to our system here in the United States?
So I think still the importance of primary care, I think, is still, it looks to me underdeveloped in the US. Once you've got a population register combined with that huge amount of data that's held within primary care, there's a huge amount that you can do to improve people's health and improve the efficiency with which care is delivered, reducing ineffective care and promoting effective care. So I think that's one lesson, whole population. Second, I think, is that in thinking about value, there are the explicit things, the things that we have identified and measured. But also, I think the evidence is that societies value that there are implicit things that go back to the values of society reflected in the way in which we pay for healthcare systems. So I think ensuring that our payment mechanisms and are in line with societal values is another really important lesson. And I think that comes across from looking at many of the European systems. And I think a third really important lesson that's emerging is that healthcare systems, the results that individuals derive from healthcare systems are the product often of multiple interventions from hospitals, from primary care, from nurses, and from broader society. And that the healthcare systems behave as complex systems, not as complicated systems. And the significance for that is that the way that we set goals for systems is still too fragmented. The way that we have allowed incentives across the providers of care to become misaligned is really important. And the way that we need to provide the data for the frontline staff to be able to adapt and understand the care they're offering in relation to the individuals, that needs to change. So I think so the ability to manage, to lead and shape systems as they are complex systems with shared goals and aligned incentives, I think that's increasingly an important lesson for healthcare systems on both sides of the Atlantic.
Nick, it's been a delight to spend time with you. Thanks so much. There's more for us to explore. We'll do it at a future time, and appreciate very much the chance to talk with you today.
It's been a great pleasure indeed.
We are so appreciative to have Dr. Nick Hicks with us. Arranging the schedules is sometimes difficult internationally, but he was able to pull it off, and we really appreciate that. Next up is Dr. Julie Gerberding. Dr. Gerberding is the Chief Patient Officer and Executive Vice President at Merck, and was a colleague of mine at HHS as she served as the Director of the Centers for Disease Control and Prevention from 2002 to 2009. We'll hear from her on October 8th, and we really look forward to her insights and perspectives. We again would point out and recognize the symposium that drives this, the Value-Based Healthcare Symposium. We are in the midst of reframing that as an online symposium, and more information will be available directly. And again, we thank our co-hosts, the David Eccles School of Business at the University of Utah and the Green Templeton College at the University of Oxford, along with our contributing co-sponsors. Thank you.